Thank you, Chairman. This is Sook Lee from Sejong Hospital. Good morning and good afternoon, everyone. I'll try to do my best with mask wearing. Today I'll talk about the imaging of hypertrophic cardiomyopathy very briefly. So, as you all know, the hypertrophic cardiomyopathy is the most common genetic heart disease, and it has a mutation in genes coding for sarcomeric proteins. It is known as the most common cause of sudden death in young, including athletes. And it has various phenotypic heterogeneity and incomplete penetrance. So very very many kind of morphologic variations. It can be diagnosed when LV and diastolic thickness of LV is more than 15 millimeter in adult. But when the patient has a family history of hypertrophic cardiomyopathy, it can be, the threshold can be a 13 millimeter. And not necessarily mandatory, but septal to posterior wall thickness ratio is more than 1.3 usually. And in the absence of identifiable cardiac or systemic cause of LVH. Hypertrophic pattern of HCMP is very diverse, but typically there is asymmetric septal hypertrophy, but it can be extensive and diffuse to mild to segmental hypertrophy. Anterior septum is the most frequently involved segment, and followed by posterior segment and lateral free walls. There is a classic Maron classification, type 1 to 4. But there is other diseases that can cause LVH other than sarcomeric mutations. So we have to differentiate hypertensive LVH, aortic stenosis, athlete's heart, non-compaction cardiomyopathy, and other infiltrative heart diseases such as Fabry, sarcoidosis, amyloidosis, endomyocardial fibrosis. It is not easy to differentiate by just looking at the echo, but pathologically, HCMP is characterized by this area of mitral fibrils and fibrosis compared to other diseases, other LVH, other hypertensive LVH, and when we apply the speckle echo strain compared to athletes LVH and hypertensive LVH, hypertrophic cardiomyopathy shows a decreased longitudinal strains, as you see here. And in right side, right lower side, apical HCMP has a more severely decreased strain, and especially in apex. And this strain was correlated with number of segment with fibrosis and mass, as you see here, not with LVF. And this hypertrophic cardiomyopathy has various clinical manifestations, and one of the devastating is sudden cardiac death by arrhythmia. And but most of the patients have HFpEF, and followed with atrial fibrillation and risk of stroke, and a portion of patients have obstructive hypertrophic cardiomyopathy and have heart failure symptoms, and a small proportion of patients may progress to end-stage advanced heart failure. But the diagnosis is very important because we have tools to prolong their survival rates. The most important part is the screening of family members of HCMP and prevention of sudden death and prevention of progression to heart failure. As you see here, obstructive cardiomyopathy can be, the survival rate can be improved with septal myectomy. And when you find appropriate patient with high risk of sudden cardiac death, such as severe LVH in young population, we can save their lives by implanting ICDs. And echo and MRI is the two most important tools to assess the HCMP. And echo has a better temporal resolution compared to MRI, but MRI has better spatial resolution. So morphology, like extent and site of hypertrophic segment and LV apex, LV lateral walls, those can be evaluated better with CMR, but dynamic obstruction and mitral regurgitation, hemodynamics can be better evaluated with echocardiography. And the tissue characterization, one of the most important part of HCMP, is better evaluated with a CMR. And when we plan to go to operation or procedures, MRIs can give us better imaging information. So those are two tools are very complementary each other. Let me show you several cases of our hospital. This is a male, 20-year-old male patient presented with a syncope and had a diffuse LVH, and the strain was very decreased. And their MRI, there was a late gadolinium enhancement in septum, and especially a junction of RV and LV walls, and patch gadolinium enhancement in septum and apex. This is another patient who had presented, 29-year-old male, presented with aphoric dyspnea and chest pain, and had severe LVH in septal hypertrophy and basal septum. The strain was decreased, and severe enhancement in septum. And these, in another case, female, 55-year-old, and had a decreased LV systolic function. The LVH was not that severe, but she had an asymmetric septal hypertrophy and late gadolinium enhancement in septum diffusely. So this LGE is a very characteristic in hypertrophic cardiomyopathy, and typically they are seen in hypertrophic segment and a junction of LV and RV wall, and it's thought that because of there is a tension from the hypertrophic segment, the ischemic injury and occurs in those areas. And there are several articles. There are several articles showing the correlation of gadolinium enhancement and pathology, and these authors showed that this MRI LGE was associated with intramural coronary artery dysplasia, and these authors showed that this scar in pathology was correlated with collagen accumulation. So this, I think I spent too much time, so let me end here.
So let's move over to Dr. Jung-Sun Kim, the pathologist, looking at the specimens of hypertrophic cardiomyopathy. Dr. Kim?
I'm going to show you a couple of real heart HCMP and some three-dimensionally reconstructed heart of HCMP. First one, this one, yes. Can you see? Yeah. This heart is already cut short axis. This is the apex part. When you look at the middle part, where the thickness of the left ventricular wall, maybe this part were similar to normal heart, but when you look at anterior and septal portion, it's severely, markedly thickened. You can recognize. And also here, as Dr. Lee already mentioned, there are scar portion, whitish, fibrotic area, replacing myocardial loss. Maybe we can see another, look at another one to see the subaortic portion. Hypertrophy of left ventricular wall is not as much as thick as the previous one, but this one also shows thickening of myocardium of anterior wall of the left ventricle and the septal portion compared to lateral part of the left ventricular wall. This is short axis, but when we cut the heart to see the subaortic portion, here you can see the aortic valve and mitral valve, and here is the basal portion or upper portion of the interventricular septum. Here, the interventricular septum is protruding toward subaortic outflow portion to make obstruction below the aortic valve. And in addition, the mitral valve is enlarged and also thicker than normal, so it is related to systolic anterior motion of the mitral valve. Maybe I will show you some three-dimensional reconstructed heart from cardiac CT. This model is a three-dimensional reconstruction of a luminal side instead of the wall part. So here, this is your right ventricle, left ventricle, pulmonary trunk, and this is left anterior descending coronary. So it means this part is anterior part of the left ventricular myocardial wall. So compared to the other part, it's thicker. But this is the diastolic phase, so it's relatively thick, but not that much. But when you look at systolic phase heart, this is the three-dimensional heart of the systolic phase. So here, luminal side is much smaller. And here, this is the left anterior descending coronary. So that means the left ventricular wall thickness is like this. Maybe it's better to compare side by side. In order to emphasize the subaortic outflow portion, I will show you the long axis echo view of the same heart here. So this is the left atrium, left ventricle, and here is the aortic valve, and then aorta. This is diastolic phase. So the left ventricular wall is thick, but still the aortic outflow portion is open. But when you look at the heart of systolic phase 1, the same axis view, so left atrium, left ventricle, aorta. Here, the anterior wall of the left ventricle is much thicker, and then is attached to mitral valve to make obstruction of the subaortic portion. So I showed the asymmetric hypertrophy of the left ventricular myocardium and some whitish scar area and the subaortic obstruction during systolic phase. That's all for today. Thank you.